Hi everyone. In this video, we'll very briefly go over some basic terms and patient examination as they relate to fixed prosthodontics. In fixed prosthodontics, we use fixed prostheses or artificial substitutes that cannot be removed from the mouth by the patient to replace a missing tooth or teeth or to restore a tooth or teeth. And obviously, we need to restore the teeth to proper function, form, aesthetics, and comfort and health of the patient. So, fixed prosthodontics can cover anything from something as simple as restoration of a single tooth with a crown to something as complex as rehabilitation of the entire dentition that involves multiple crowns or multiple implants that support a fixed prosthesis. Now, let's go over some very basic terms to just kind of warm ourselves up a little bit. So, extra means outside or outer, and intra means inner. And coronal as a term refers to crown. Therefore, an extracoronal restoration is a restoration that covers the outer surface of the clinical crown. And intracoronal restoration fits within the anatomical contours of the clinical crown. A crown, for example, is an extracoronal restoration because it covers the outer surface of the clinical crown. Now, depending on the amount of coverage that it provides, it can either be a full coverage crown, meaning that the crown covers the entire tooth surface, or it can be a partial coverage crown, meaning that the crown covers only part of the tooth surface. This is an example of a 3/4 crown, wherein the buccal surface of the tooth is left relatively unprepared, so it is more conservative than a full coverage crown, and the rest of the tooth structure is covered by the partial coverage crown. An inlay is a restoration that restores only part of the occlusal surface of the tooth, and it doesn't restore the cusps of the tooth. So it's restricted to the part of the occlusal surface that's between the cusps, and it could include some part of the proximal surface as well, depending on the amount of restoration that's needed. Now, an onlay is different from an inlay in the sense that an onlay restores the cusps as well, in addition to the occlusal or proximal surfaces. A fixed partial denture is a prosthesis that replaces one or more missing teeth. Now, when we replace a missing tooth or teeth, we use the adjacent tooth, teeth, or implants as support for the prosthesis. We'll be talking more about tooth-supported prosthesis for now. So the teeth that are used as support for the prosthesis are called abutment teeth or abutments. Now it's actually derived from architecture where abutment is a part of the substructure that provides support for the superstructure. So in this case as well, the natural teeth provide or the abutment teeth provide support for the superstructure, which is our prosthesis. This is just additional information. When we look at the prosthesis itself, the part of the prosthesis that goes over the abutment teeth are called retainers. The part of the prosthesis that replaces the missing tooth is called a pontic, or if it replaces multiple missing teeth, it's called pontics. Now we need something that connects the pontic to the retainer, and that's what is called a connector. A nice way of remembering this is to use the mnemonic CPR, which actually stands for cardiopulmonary resuscitation, but can be used to memorize the components of the FPD as well. Moving on with the diagnostic examination. Now, we've all probably read this so many times in different textbooks because that's just how important it is. Um, Only a complete diagnostic examination can help us in coming up with a treatment plan that is tailored to the patient's needs and modifying factors. No two patients are the same. Different patients have different needs and expectations, oral conditions, and overall health. And prosthodontics, especially, is all about treatment planning. So that makes the diagnostic examination even more important. Let's very briefly go over the 5 important elements of a complete diagnostic examination. The first one is patient history. Now, patient history consists of personal details, chief complaint, and medical and dental history of the patient. In personal details, we note down the patient's name, age, address, occupation, habits, etc. So it helps us in developing a rapport with the patient. For chief complaint, and you've probably heard this 1,000 times over, but I'm going to say it one more time, preferably recorded in the patient's own words. It's because the patient has the best idea of the problem. And sometimes it may so happen that upon clinical examination, we might come across problems that the patient is unaware of, and something that's more severe than the patient's chief complaint, probably. But it's important to understand that the patient perceives the chief complaint as the major problem. So at the end of our treatment planning, we need to make sure that the patient's chief complaint has been adequately addressed apart from the other issues. Now, chief complaint is usually related to comfort. For example, the patient may have pain or swelling, or it can be something that's related to function, like inability to chew food or speak properly, or a general dissatisfaction about appearance. Whatever it is important to explore it in greater depth. For example, if the patient has pain, it is important to note down the location of the pain, the duration, the character, the factors that increase or decrease the pain, and so on and so forth. Lastly, but most importantly, never overpromise and underdeliver. We should never guarantee the patient an end result that we're not sure of, or an end result that we're not capable of. It will result in a lot of disappointment down the line, so never do it. Medical history is super important, and even more so with the current pandemic situation going on. Now, regardless of if the patient has an infectious disease or no, it's an absolute must to use universal precautions. Now, there are certain conditions that can affect the treatment methods. For example, the patient may be allergic to penicillin, so we might use an alternative antibiotic, preferably clindamycin, in such a patient. Or a patient may be at a high risk of developing something like infective endocarditis, so we need to pre-medicate the patient with an appropriate antibiotic prior to treatment. So these are the things that we should note down to avoid complications in the future. There are certain conditions that can affect the treatment plan. For example, patients with terminal illness or ongoing chemotherapy, we might choose to defer elective treatment. There are also certain systemic conditions that can have oral manifestations. A very common example is xerostomia, that is that occurs with certain autoimmune diseases. A very common example being Sjogren's syndrome. So that can give you an insight into the patient's medical condition sometimes. Or xerostomia is also a side effect of many drugs like antihypertensives and anticholinergics and many other drugs. So that also could give us an insight into the patient's medical condition. Let's go over a few medical conditions and their importance. Now, this is by no means a very detailed list of all the medical conditions and precautions that we should be taking. It's just a very brief overview to highlight the importance of medical history. Now, with medical conditions like cardiovascular disease, diabetes, epilepsy, bleeding disorders, etc., it is important to first consult with the patient's physician before proceeding with dental treatment. Coming to cardiovascular disease, the most common one being hypertension. In patients with uncontrolled hypertension, no dental treatment should be carried out until it is brought under control, ideally under 140 by 90 millimeters of mercury. It is also important to manage stress in these patients and make the appointments less stressful for the patients, because we know that stress triggers the release of the patient's own epinephrine, and that increases the blood pressure levels, and we definitely don't want that. In patients with severe cardiovascular disease like unstable angina, we avoid the use of epinephrine in local anesthetics. Now, antibiotic prophylaxis has been recommended only for patients at the highest risk of developing infective endocarditis, like patients with prosthetic heart valves or a patient who's had infective endocarditis in the past. Some patients may also be on antiplatelet or anticoagulant therapy for conditions like, say, atrial fibrillation or pulmonary embolism. So for these patients, always consult with a physician to check if temporary discontinuation of the therapy is required before any procedure where bleeding is anticipated. Coming to allergies, it is important because an accidental exposure can trigger an anaphylactic reaction, which can be life-threatening. So, very important to note down any potential allergies that the patient could be aware of. The most common drugs that are implicated are local anesthetics and antibiotics, especially penicillin. The patient can also report a reaction to dental materials like alloys containing nickel, which can be used in dental prosthesis, or a latex allergy. So make a note of that as well. With epilepsy, it is important to control anxiety and avoid tiring appointments for these patients because all these things can precipitate a seizure episode. Now, these patients sometimes lack the motivation to maintain oral hygiene because of some kind of physical or mental handicap. So, the importance of maintaining oral hygiene should be reinforced to these patients. We know that phenytoin has gingival hyperplasia as a side effect, and many anticonvulsants also cause xerostomia. So, it is important to plan restorations accordingly. Speaking of restorations, fixed prostheses are always preferred over removable prostheses because removable prostheses carry the risk of aspiration and choking or choking if the patient has a seizure episode. For patients with diabetes, we make sure that the blood sugar levels and A1C levels are optimum. We also make sure our appointments are less stressful to the patient because stress causes the release of cortisol, and cortisol raises blood glucose levels. Now, we also know that diabetes predisposes the patient to delayed wound healing and is also a modifying factor for periodontitis and can also cause xerostomia by itself or as a side effect of medications that the patient could be taking. Now, xerostomia predisposes the patient again to caries, which further complicates the situation. So, when providing restorations, we make sure that we place the margins of the restorations in areas where the patient can clean them easily. And we also emphasize the importance of oral hygiene maintenance in these patients. Secondly, coming to MRONJ, which stands for medication related osteonecrosis of the jaw. Now, it's not a medical condition in of itself, but it's a side effect of medications, a group of medications called antiresorptive agents. So, these group of medications, they slow down the osteoclastic resorption of bone. So it's used for treating conditions like osteoporosis or bone metastases, etc. So any kind of uh, treatment that requires bone remodeling is delayed or contraindicated. So any kind of extraction or implant therapy is delayed or contraindicated. Now, xerostomia, it's a very common side effect of a lot of drugs. It can also be caused by irradiation therapy to the head and neck or by autoimmune diseases like Sjogren's syndrome. It can complicate our treatment because xerostomia predisposes the patient to caries, especially around the margins of dental restorations. So we need to again emphasize the importance of maintaining oral hygiene in such patients, and we could prescribe the patient some kind of fluoride toothpaste or mouthwashes or professional fluoride application on a regular basis or artificial saliva replacements. Or it can also cause difficulty in tolerating dentures. The patient may find it difficult to chew and swallow, so appropriate therapy is a must. Extraoral examination, which is the second important element of a diagnostic workup, we evaluate the extraoral structures like the facial profile, presence of facial asymmetry. We palpate the cervical lymph nodes. We palpate the temporomandibular joints and the muscles of mastication. We take a look at the lip support, the lip line and smile lines, etc. So coming to TMJs and masticatory musculature, it is very important for these structures to be in a state of perfect health because the restorations or the prosthesis that we place need to be placed in a harmonious relationship to these structures. So only if they are healthy will they be able to tolerate or accommodate the restorations. So we need to check for any kind of dysfunction like pain, clicking, limited mouth opening or deviated mouth opening, or tenderness when we palpate the masticatory muscles. And it is important to address these before moving on with prosthodontic treatment. I'm sorry about some of these shabby diagrams. I'm still trying to get used to Microsoft Paint. Now, that aside, when we take a look at the patient's lips, when during normal and exaggerated smiling, we look for something called the lip line. So, a patient with a high lip line will show a lot of gingiva, and a patient with a low lip line will hardly show any gingiva. So, a patient such as this will be a high aesthetic risk patient, and we really need to plan our treatment properly and execute it to perfection because any kind of restoration will be easily visible if not done correctly, or any kind of gingival recession from restorations that are improperly placed will be easily visible. So, that has to be kept in mind. Also look for any kind of compromised lip support for patients who have been missing their anterior teeth for a long time, and check if a fixed prosthesis will be able to compensate for the compromised lip support, or you could use a removable prosthesis that has a flange for better lip support. Coming to intraoral examination, we perform a thorough evaluation of the teeth, the periodontium, and other soft tissues like the tongue, the buccal mucosa, floor of the mouth, etc. A thorough dental and periodontal charting is a must. We also have to look at the health of potential abutment teeth and make sure there is no kind of structural or periodontal compromise. We look at the edentulous ridge and look for bone loss. We check the existing occlusion and look for things like wear facets or occlusal interferences. We'll talk about occlusion in the later videos. So the overall oral health of the patient can give us an idea of the prognosis of the restorations that we might place, or it could give us an idea of how well the patient is able to maintain his or her oral hygiene. The fourth important element are diagnostic casts. Now, accurate diagnostic casts that are mounted on a semi-adjustable articulator are an absolute must for treatment planning. When we perform a routine clinical examination, there are often many things that could go unnoticed or might be impossible to evaluate. For example, the lingual cusps of posterior teeth or the actual inclination of abutment teeth, things like that. So, with casts mounted on an articulator, we can have a look at it from every angle. So we can evaluate the occlusion thoroughly or do some kind of trial and error procedures on the cast before we do it on the patient. Or we could even do something like a wax up on the cast to show the patient what the end result of the treatment would look like. The final element, full mouth radiographs. Now, it's important to understand that radiographs are not an alternative to a thorough clinical examination. They only supplement the clinical examination in helping us narrow down the diagnosis and facilitate treatment planning. Certain things that can be overlooked during clinical examination, like secondary caries or proximal caries, periapical bone loss, etc., can be evaluated in a radiograph. Also, especially important to evaluate the abutment teeth, have a look at the morphology, the crown to root ratio, uh, any kind of caries or restorations on abutment teeth, or presence of periodontal bone loss. We'll talk about how to evaluate abutment teeth later in the later videos. So that's it for now. It was longer than I anticipated. Feel free to pause for a few seconds and try out a few questions. It'll help me gauge how well I've been able to communicate and help you assess how much you've understood as well. It's pretty easy. You can find the answers in the description box. Thank you so much for staying with me, and I hope it wasn't too much information at one time. Feel free to post any kind of comments or questions or feedback that you might have. I'll see you in a while. Bye.